So I'm Emma. I am an internal medicine resident at OHSU in Portland, Oregon. I am happy to be back. I helped start this a while ago, and amidst kind of the pandemic when I was in medical school, and it feels like quite some time. And I'm happy to be back. This is something I enjoy doing, and I'm hopeful I can teach you guys something today. So without further ado, let's get started. So this is a little bit about me. I always cringe when there's like an about me slide. So bear with me for this one. So I went to the University of New Mexico. That is the Lobos. A lot of people don't know New Mexico is a state. So if there's anybody from New Mexico there in the crowd today, I'm sure you can attest to that maybe. I left for a little bit of time after I finished my undergraduate education and went to Maryland, and then ultimately ended up coming or going back to New Mexico and did medical school there. And then I came, even further out west to Portland to do my internal medicine residency. And I'm currently a PGY2, a second year resident, about to start third year in a couple of months, and kind of gearing up to apply for an addiction fellowship as well. And in terms of my passions in medicine, I do a lot of work with narrative medicine, global health advocacy, and medical education. Hence why I'm here today. With Motivate MD, I've worked with them for quite some time now. I started with editing and do advising as well as contribute to blogs and obviously virtual rounds and do some mock interview stuff. What you see up here is my Twitter or X handle. I have the only form of social media that I have is Twitter, because I think there's a lot of good medical education stuff on there, and so I do use that. If you're late, no worries. If you're just joining us, I'm happy you guys are all here. Otherwise, kind of over here, a couple of pictures. This one is at a conference, an internal medicine conference with some of my colleagues and I. And then this picture down here is of my dog with a stethoscope around its neck. That's really all I have to kind of say about me. You guys feel free to always ask questions in general, not just about me, but in general. I do have the chat box open as well and kind of can monitor that as well. But we'll kind of continue here. The first thing I like to do is there should be an area where you can add kind of a stamp if you go up to the toolbar at the top and kind of show me where you're at today. I like to kind of get a good idea where all you guys are from. I see you guys adding on there. Thanks for doing that. You guys are getting good at Zoom, I'm sure. Looks like there's always a good like Canadian presence, and I always appreciate that. I want to go to Canada for my vacation this year. Let's see, there's some Houston and Dallas. Awesome. I hope you guys are safe from all the flooding and stuff. I know that that kind of was an arduous situation. Okay, looks like some Tennessee. Love it. Cool. There's some Northeast. Good. It might be late for some of you guys. I appreciate you being here. Massachusetts. Awesome. Well, great. Well, wherever you guys are from, thanks for being here. I think we have a good case on pancreatitis today. Let me clear all these drawings so they're not in our way. What we're going to start with today is I'm going to share this pre-poll, and feel free to answer this kind of to your guys' comfortability with the topic of pancreatitis. It's okay if you don't know anything. That's all right. When I was in your shoes, I knew a very small amount of things, probably less than you guys know. But we'll see kind of over time if in the next hour or so we can teach you guys something about pancreatitis. Awesome. So it looks like kind of the predominant, I'll share this with you guys and you can kind of see here. It looks like the predominance is kind of between I know nothing and I know a little bit, and that's totally okay. And sorry about that. My dog is, he only makes noise. The one that had the stethoscope around his neck, he only likes to make noise when I'm like on a meeting. And otherwise, he'll be napping. You guys know how dogs are. Okay. So I'm going to stop sharing that. It seems like most of you guys are kind of in that delineation between, kind of not a lot about pancreatitis and maybe some in terms of, a little bit. So that's totally okay. All right. Let me move this poll out of the way and then we will kind of get going here. All right, so here's the session outline. Basically, what we're going to do today, we're going to go through an introduction on the pancreas. I do have a case for you. And then we kind of will go through a differential. We'll go through the physical exam. We'll go through the assessment and plan. And then we will kind of go through the lesson on kind of the pathology of the disease. And what you guys will do, fill out the SOAP note. You guys should have gotten that in the email before with the link for this. And basically what that looks like is this, which is on the next slide, and basically you'll go through and to kind of review what SOAP means. It's an acronym. And we use it often to kind of document things in medicine. And some of you of whom are scribes may be familiar with this acronym or familiar with these aspects of clinical documentation. The first is for subjective, and that's basically kind of this history of present illness, so what's bringing them into the hospital. And then the other thing is ROS, which is review of systems. That's a pertinent positives and negatives for what the person is coming there for. Next, the other thing is objective information. So these are things like vital signs, physical exam, lab findings, things like that. Then finally, we'll talk about an assessment and plan. And this is all going to be kind of pertaining to pancreatitis. So if the patient comes in and says, I have abdominal pain that's in my epigastrium, surprise, that goes in the subjective area. And then if you get for instance, some sort of imaging or lab, that kind of goes here. And then how we're going to address that goes kind of here, what you think's going on and what the plan is for that. Okay. So that's kind of the SOAP note. No pressure in terms of creating a beautiful note. We kind of recognize at your guys' level that like some of these aspects may be unfamiliar to you. That's okay. This is kind of for you to get practice with some of these things and kind of get a little bit of practice of thinking like a clinician, essentially. Okay. So let's continue here. So first things first, let's talk about a little bit of anatomy of the pancreas. And no kind of discussion in medicine is, I think, complete without the anatomy. So let's talk about first the image on the left here. There's a few structures that I think are important to pointing out surrounding the pancreas. And before we kind of talk about the pancreas itself. So first things first, you kind of probably recognize these guys here and here. These are your kidneys, the left and right kidney. And then kind of surrounding it, you'll kind of see the duodenum. The duodenum goes right here. And then the two structures kind of relating to the duodenum, part of your intestine, that is important for the pancreas would be your minor and major papilla, and they kind of go right here. And those are the things when you kind of look over here at this image, on the right-hand side, it's where these ducts kind of dump into. So the first one that we're going to kind of look at is right here, the principal pancreatic duct, and everything has to have 50,000 names in medicine, which is Worsung's. And by the way, if none of this is making sense, feel free to stop me, ask questions, put questions in the chat. I'm happy to be interrupted, and I'm happy to interact with you guys too. The less talking I have to do is probably better for everybody. Then the other part that kind of corresponds in this image to the minor papilla would be the accessory or the pancreatic duct, which is the duct of Santorini. Sometimes you'll see it called, depending on how old the textbook is. And so they kind of dump, if I were to draw the duodenum here, which is probably better if I don't do that, because you guys will see how bad my art skills are. So here's what the duodenum would look like here. And so you can see the major papilla would be here, and the minor papilla would be there, and then the major papilla. And then, as you may have guessed, this common bile duct kind of corresponds and dumps bile from the gallbladder, which goes like right kind of up here, not really. It kind of then branches into the left and right or the left and right ducts, and then kind of dumps bile into the common bile duct. And so, as you can see, kind of the pancreas is in the middle of a lot of different things. Otherwise, the other things that are important to kind of notate is posteriorly, meaning behind the pancreas, you see the IVC as well as the abdominal aorta. And those are two major vessels that are important to circulation in the body. And then our friend the spleen is over here as well. And there's some other aspects here that I didn't mention, but doesn't mean they're not important. So let's keep going here. And I have some histology for you kind of on the next slide here. And if you guys have questions, let me know. So here's the next thing, and we kind of talked a little bit about this a second ago when I talked about here's where the digestive enzymes get dumped into the duodenum. The other thing that I think is important to mention here is what makes up these cells that are in the pancreas, and it kind of tells us why things happen the way they do. And everybody may be kind of familiar with the pancreas for the one disease that kind of is its claim to fame. If you guys know that, shout that out in the chat. I'm sure you know exactly what I'm talking about. But as you can see here, here's a cell that makes up, or an islet that makes up, nice, diabetes. Somebody threw it in the chat. You're absolutely correct. So good. And then, so here is a histology picture, and then there's another one down here in the bottom right that is making up the cells that are in the pancreatic islet cells. And there's a few of them, and we're going to kind of talk about them here. But the first one that I want to talk about, which is the pancreas's claim to fame here, is the beta cell. And that forms 75% of the cells. What are the beta cells doing? They're making insulin. And that's why it's important to diseases like diabetes. Whether it's type 1 diabetes, you're not making insulin, or type 2 diabetes, you're not responding to insulin. And so, as you can see, if the majority of the pancreatic islet cells are composed of beta cells, which make insulin and lower your blood glucose, you can imagine why, if you have an issue with the pancreas, you're going to be hyperglycemic or have high insulin. Finally, or not finally, but next, the other aspects that are important to mention here would be the alpha cells. And so that's what we're talking about here, which is makes up 20% of the pancreatic islet. And those release glucagon. And I love when things are named appropriately in medicine, because glucagon is released when your glucose is gone. And so as a result, it raises blood sugar. And so imagine you guys are all studying for your MCAT. You haven't eaten anything for hours, it seems. Your alpha cells might release glucagon in order to raise your blood sugar, because our bodies kind of have this homeostasis in order to balance and not allow you to go without glucose, because you need glucose for your brain, you need glucose for your heart, you need glucose for everything. Um, Next, the delta cells, which form an even smaller fraction of the cells, about 4%, releases a hormone called somatostatin, and it doesn't. I didn't actually put it here, but that's what's released here. Somatostatin. I got ahead of myself. And basically, what somatostatin does is it inhibits glucagon and it inhibits other hormones. It's also released from the hypothalamus. And so, in addition to what's released from the hypothalamus as well as from the pancreas, it inhibits other hormones in the body. And then finally, 1% of the cells in there, a very small fraction, is pancreatic polypeptide. That plays a role in appetite, and it's often released following a meal in order to suppress your appetite, basically tell your body that you're not hungry. Now, I think this image on the bottom right-hand corner does a great job of showing the proportion of cells that are in the pancreatic islet. So basically, if you took this and moved it over here, that's what we're seeing. And the cells are stained based on what they're releasing. And so or they're stained based on antibodies to insulin, glucagon, and somatostatin. Okay. And so basically, if you had to guess without reading the caption, don't read the caption, what cells would you say were in the in the pink or staining pink? Perfect. You guys nailed it. Exactly. So I would say those are beta cells, and if you're uncertain, you can read the caption. Um, but otherwise, great. You guys are saying beta cells. Now, if you had to guess about the brown cells, what would you say the brown cells were? You see a little more of those than the blue. What would you say the brown cells are? Alpha, nice, great. Perfect. And then what about the blue cells? Yeah, exactly. So those would be the delta cells that release somatostatin. Great. I think you guys are understanding perfectly kind of what makes up the pancreas. So good. Um, Excellent. So I just wanted to give you guys a little bit of context before we kind of move on here. And now here is our case. Without further ado, so basically a 34-year-old male with a past medical history, that's what PMH stands for, significant for hypothyroidism, presents to the ED for abdominal pain, which onset 4 days ago. The pain is intermittently located in the mid-abdomen, does not radiate, and is associated with nausea and vomiting that is worsened by eating fast food. It's described as a sharp and stabbing pain, radiates through to the back, and nothing really makes the pain better. He's never had this pain before, and the pain is 9 out of 10 in terms of severity. And so what we're going to do now is kind of go through what's important for history taking. And so this is I think a skill that's hard to kind of learn what the right questions are to ask, and you're often really nervous early in your training. The mnemonic I always liked when I was in medical school, and sometimes I, remind myself of it because it helps me remember the points that are important to ask the patient in terms of what's going on with them, is old carts. That's a mnemonic here on the left hand side, and it stands for if we're talking about the pain specifically, or when something onset or a symptom. It could be for nausea, whatever. It doesn't have to just be for pain, but often this mnemonic kind of tends itself or like lends itself to pain. O is for onset, so when did it start? L is for location. D is for duration. So how long has this been going on? We know that that was 4 days. Characterization. So is it sharp, dull, aching, cramping, etc. Aggravating and alleviating factors. So aggravating is like what's making it worse. Alleviating is like what makes it better. Radiating, does it travel anywhere? And I often recommend whenever you're talking to patients about this is asking them like, does it travel anywhere? Not does it radiate anywhere? Because often they're like, what does that word even mean? And then the timing of it, is it constant or does it kind of wax and wane? Is there any kind of variation in the pain? And then severity, is that like classic scale from 1 to 10, or having them use whatever scale makes sense to them. Though the 1 to 10 scale seems to kind of standardize it at least a little bit. So with that being said, let's kind of cue into our old cards. It's down on the bottom right hand corner. You guys tell me what is the onset. You guys can throw it in the chat or say it out loud. And Chris, great question.
4 days
said,
ago?
Yeah, exactly. Perfect. Thanks for whoever said that. And then Chris had a question about using OPQRST. Yeah, I think I've heard of OPQRST. It was always really hard for me to remember what that meant. Old carts like kind of stuck in my brain, but if that works for you, that's perfect, or whatever mnemonic works best for you. But you guys are right. The onset is 4 days ago. What about the location? Perfect. Yeah, mid-abdomen. Good. And then duration? Yeah, intermittently. Perfect. Characterization. What do you guys think about that? Yep, it's sharp and stabbing. Good. And the aggravating and alleviating factors. Perfect. Worsened by fast food. And then good. And then doesn't get better really with anything. You guys are right. Perfect. And then the timing, what about that one? We kind of talked about it a little bit. It's intermittently up there. I revealed the radiating factor, which is it radiates to the back and gives us a little more information with what we're dealing with. And then the severity, we know that that's 9 out of 10. That one's pretty simple to kind of pinpoint there. So good. You guys did great with that. Let's continue here. And one of my questions that I have for you all is, what social history questions are important to ask? So like, what do you want to know about this guy's life that might clue you into what's going on with them? Yeah, sure. His medical history. We know a little bit about that he doesn't have any past medical history, but I think you're absolutely right, Iris. Chris says alcohol use, smoking, recent travel. Sure, I agree. And any high blood pressure, yeah, certainly. With high blood pressure, we know that the abdominal aorta is kind of in that area. We talked a little bit about that earlier. Recent infections or vaccinations, certainly. How often does he eat fast food? I agree. It sounds like the fast food's kind of making his pain worse. So what's going on with that? Age, diet, relating to lifestyle, perfect. Any allergies? Totally. I agree. Perfect. You guys are kind of spot on with the social history. One thing I think somebody hasn't, yeah, past surgical history, agree. One thing I don't think anybody has said just yet, but maybe somebody's typing it, is if they smoke cigarettes or any illicit drug use. I ask everybody that. And it could be because I want to do an addiction fellowship, but I ask everybody that because it plays into a lot of disease processes, whether they smoke anything, whether it's cigarettes, use any illicit drugs, or use any alcohol. Good. The next question I have for you is, the aggravating factor important here, or is it coincidental? If you guys remember, somebody very diligently pointed out before that it's worsened by fast food. Is this coincidental or important? Yeah, Iris says important. Does anyone want to tell me why it might be important? Yeah, saturated fats and lipids, which come from, do you guys know? We talked a little bit about our friend anatomically. Certainly. Yes. Yeah. Chris says bile. I agree. And it goes through the pancreas, so you're not wrong. But yes, so a lot of fatty foods, fats are emulsified in the pancreas, or not, that's not true. Take that back. Emulsified in the gallbladder. So they're released bile that emulsifies fats. And so if you're eating fatty foods all the time, your pancreas is going into overdrive. So it's often not coincidental that um, some of the pain is released when, or exacerbated by when there is fatty foods. And so we'll talk about the importance of that later as well. Yep, exactly. Fatty foods broken down into bile and then imported through the pancreas. Exactly right. And then we know that if you have an issue with the pancreas or the gallbladder, whether that's stones, etc., can cause an issue. So the next thing that I want you guys to kind of think about is like, what imaging or labs do you want at this point? You can kind of throw things in there. I want you to be as specific as possible in terms of like what's going to pinpoint our diagnosis. Oftentimes we kind of do this broad workup to kind of rule out other things, but I want you guys to kind of get to the meat of it here. Chest X-ray, certainly. What are you looking for with the chest X-ray? Somebody said MRI. You want to see the blood pressure? MRI. CT. Okay. Looking for enlarged organs. Okay. You can get an LDL. Yeah. I'm always, as an internist, I'm always looking at the cholesterol. That's important. Abdominal CT, BMP, A1C, and insulin. Okay. Ultrasound. Ultrasound of what, Isabella? What are you looking at specifically? CBC, certainly we want to see if this is an infection. LFTs, let's look at the liver. Good. We can get some blood tests, certainly. These are all good. And then my blood cultures, yeah, if you think they're infected, I think it's good. We'll see what the labs or the vitals and stuff show, and you can tell me if you think that this person is infected and whether you want to get a blood culture or not. And now what's on your radar for a differential? And like, obviously, I think you have one thing in mind because of the title of this talk, but what else do you want to consider in this person? Think of the surrounding structures too. Good. Yeah. So pancreatitis, I see GERD. Somebody said kidney stones. I think that's good. Yeah, something related to the kidneys, maybe pyelonephritis. It's an infection of the kidneys, pyelonephritis. Cirrhosis, totally, especially if they drink a lot of alcohol. Um, and then good. And then they mentioned some pain that radiated to the back. I'm always thinking about the aorta. And then somebody said gallstones. It's called cholelithiasis if there's gallstones, and if it's an inflamed gallbladder, we call that cholecystitis. AAA, yeah, great. I'm thinking about a AAA too, especially if someone has central abdominal pain and low blood pressure. I'm worried. Great. Well, let's keep going, guys. I have a physical exam for you here. Let's go through it together. This person is like not febrile just yet. We kind of think of 100.4, but like sometimes you hear this like low grade temperature. So maybe that. Is this heart rate fast or slow? Yep, tachycardic. That's exactly what we call it. What about this blood pressure? Are we happy about it? It's a little low, yeah. Yep. Someone said nope, they're not happy about it. Yeah, it's like normal-ish, but like low. It's not making me feel comfy. It's making me feel a little uncomfy. Um, and then the respiratory rates, like maybe he's breathing a little bit fast, but we'll look at the rest of the exam and see what's going on. Um, yeah, tachycardic soft blood pressure. Yep. So the patient's in no acute distress. Okay, good news. So you have a little bit of time to talk to them. Lungs are clear. The patient is tachycardic, but no murmurs, rubs, or gallops. And then otherwise, the abdominal exam, which is like what we want to kind of focus on here, is the patient is soft, or I'm sorry, the abdominal area is soft, and there's some tenderness to palpation over the right upper quadrant, as well as the epigastrium. And we'll talk about where those areas are in a second. And then otherwise, the patient's not having any rebound tenderness, no guarding, which means that when you push in, there's not more pain when you let go, and no guarding, meaning like their abdominal muscles are not like firm and like they're protecting their abdomen from the pain. Otherwise, the patient's alert and oriented and not without any focal neurologic deficits. Okay, so pretty like overall reassuring exam. Does have some abdominal tenderness. So let's take a look at some labs here. Right upper quadrant. Yeah, we'll definitely talk about that. Whether it's what kind of it's relating to. So great thoughts, Chris. I love it. So here is a image that I'm going to show you here. And basically, what this is showing here is that this clinician is kind of right below the right costal margin, so right above or right below the ribs, and is pushing into the patient's abdomen there and having them take a deep breath. And what we know is going to happen with this examination is that when they take a deep breath, their gallbladder and their liver should come up and hit your hands or come close to it. And if you have an inflamed gallbladder, it's going to be painful. And so with this patient, they did have some tenderness with the Murphy sign. And so that tells us maybe there's something going on with the gallbladder. And so take a look at these labs and tell me what you guys think of these. Obviously, some are in red, but there's a key in the upper, there's a key that kind of tells you right in the upper right-hand corner about what these labs mean in these fishbone diagrams. But what are you guys worried about? There are some things that are kind of a little bit sus here, if you will. But what are you guys thinking about? Glucose seems a little bit hot. So glucose is over here. That's actually a normal glucose. And then WBC count, we see that this is high. It's in red for you too. So maybe inflammation, maybe infection, hard to know. And then there's some eosinophils that are a little bit high here. Not too sure why that's going on. And then the other thing that's going on is that the patient's pancreatic enzymes are a little bit elevated here. Lipase, yes. So Colleen says high levels of lipase is of concern for pancreatitis. And then amylase is also high as well. And so with this, what do you guys want to do? You got these labs and they're like, up to you guys. Your attending's away, all the residents are away. It's all up to you guys to order whatever tests that you want. Somebody said, oh boy. Yeah, it's nerve-wracking. You have one test to order. You're putting your money down on one test. Ultrasound of the pancreas and gallbladder. I think that is not a bad choice. Does anybody else have any ideas? Or anybody else want to put their money on something else? Okay. Someone else is agreeing with Chris. Nice. Good. There's no wrong answers. You guys can throw out anything. This patient will survive. PFT, like pulmonary function test. Oh, pancreatic function test. I see. Okay, great. I know PFT as pulmonary function test. So I was like, we could do that. Yeah, so I mean, we have amylase lipase. And is there anything specifically you're looking for in terms of pancreatic function? Blood cultures? You certainly could. The things that I look for in terms of like meeting SIRS criteria, so kind of relating to sepsis, is fever, tachycardia, increased respiratory rate, oops, and then hypotension. So this patient is like borderline, like kind of feeling Searsy, but not yet Searsy. So I would hold off on a blood culture, but I wouldn't think you'd be wrong for doing that. Nobody's gonna slap your hand for that. So I'll tell you what I would do, which is I would get a CT scan. This person's like worrying me. So this patient doesn't meet SIRS criteria and therefore is not septic. So septic is like when you have an elevated lactate, in addition to meeting 2 out of 4 of the SIRS criteria. So they're like tachycardic and like have a borderline respiratory rate, and like a borderline blood pressure. But we didn't get a lactate. We could get a lactate here too. But yeah, it's like all like technicalities basically. But I mean, if you walked in and told me this patient was like SIRSy or like met SIRS criteria, I wouldn't, bat an eyelash. I'd believe it. Okay, so here you go. Here's the CT scan that I ordered. I came back and helped you guys out. I ordered the CT scan. This CT scan came complete with this red arrow that's showing you exactly what we're looking at, which is nice when that happens. But let's point out some structures that are important to look at here. So here is so what we have to remember about looking at a CT is like we're looking from the feet up. So everything's kind of backwards. So yeah, here is the right kidney. Here's the left kidney kind of coming into view there. And then we see part of the bowel here. And then what's this structure right here that I'm kind of outlining here? The pancreas, yeah, nice. You guys nailed it. And what's going on with this arrow is that basically there's some edema there. So you can kind of see like this is like the normal pancreatic tissue, and you see kind of this darkening and some fluid here in this area. And that's concerning for some inflammation and some edema. And then other structures that are important to kind of notate to kind of give us our bearings is like, here's the ribs coming into view as they kind of articulate with the spinous processes. And here's one of the spinous processes right here. Spinous process. And then over here, the liver's starting to come into view as well over here. That kind of gives us some of our bearings here. And then here's the aorta. So the aorta looks okay. There's maybe some calcification here. So maybe this is from an older patient, not from the 28-year-old that we're looking at right now. In terms of a CT scan, when we talk about what looks like what, this looks like a contrasted CT scan. We can see some contrast in the bowel here. Bones look white, air looks black. Tissues look a little bit in between because they have water. Okay. So that's what we're looking at here. We see the pancreas looks unhappy, not a happy pancreas. And so that kind of, again, lines up with this talk, which is reassuring that I didn't dupe you guys. And then somebody asked for a ultrasound of the gallbladder. I was like, great, sure, why not? Let's do it. Here's the ultrasound of the gallbladder. And let's walk through a few things. Ultrasound is really helpful. Very similarly to CT scan, air is black. And then hyperechoic structures will kind of show up as white. Or I'm sorry, hyperechoic or white. Hypo is like fluid. Air will show up as that as well. And then what we're looking at right here, as appropriately labeled by this picture, is the gallbladder. And the things that are important to look at here, let me kind of show you, is one thing in terms of diagnosing cholecystitis, inflammation of the gallbladder, is this idea of a sonographic Murphy sign. So you're getting your ultrasound probe and you're putting it on the patient's gallbladder. And usually it's not you unless you're doing like a POCUS or point of care ultrasound. And you're putting it on, you're having them take a deep breath, or you're pushing in a little bit more and it's causing pain. And so that's pretty sensitive for cholecystitis or issues with the gallbladder. That's called a sonographic Murphy sign. The other thing that we look for that's pretty characteristic is gallbladder wall thickening. And our measurement for that, and the ultrasound techs will kind of measure it for us too, is it's greater than 3 millimeters. The other thing that we see is pericholecystic fluid. That means fluid around the gallbladder. I'm sure you guys can probably guess where this is. Take a second to kind of see if you can see some dark structure around the gallbladder. And then I'll show you where it's at. I think that might be helpful for you to kind of look before somebody tells you. And that's right here. So you kind of see this fluid right here building up around the gallbladder. And then finally, you see some gallbladder distension. This gallbladder looks kind of big. And you can kind of see that here. And like, you got to see a few gallbladders to know what big looks like, truly. And then the other thing is sludge. So just seeing like a bunch of junk in the gallbladder. So one thing that you kind of can see here when you look at this is this like sludge right here. Because you can see this kind of empty spot here in the gallbladder. Then you can see some stones. So you can see the gallbladder also is not entirely happy. So great job ordering the ultrasound. I think you guys were right on point with that. So good for you. Now let's keep going here. So there's some more arrows. So there's the gallbladder distension. There's the sludge. So what's in your guys' differential right now? We talked about the pancreas, we talked about the gallbladder. Is there anything else you want to rule in or rule out before you kind of anchor on something and call this pancreatitis? Nothing comes to mind. That's okay. Nice. Bilirubin elevation. Perfect. I think you guys are kind of spot on. And I think we kind of, through our imaging, through our CT, we kind of ruled in and ruled out quite a few things. We talked about looking at the kidneys. We saw the kidneys at least in one slice and saw that it wasn't, too abnormal. And then we looked at the aorta. It didn't look like there was a rupture, a dissection, or anything like that. So, when we talk about a differential, as promised, I told you we would go through some of these things that are in this area. So right upper quadrant, so right being the patient's right, not our right, when we're looking at them. Could you get a UA to look for ketones? I would get a UA to look for two things. This is a male, but in a female, I would get a pregnancy test to rule out pregnancy, because pregnancy shows up as weird things. If it was a woman of childbearing age. And then the other thing that you can look for is like a UTI if they had any urinary symptoms. And then if you were concerned and they were pretty hyperglycemic, urinalysis. Yeah, good question, Samina. And then, yeah, if you wanted to look for ketones in the setting of high glucose, to look for like DKA, I think that that's reasonable too, or signs of starvation, ketosis. Good. Now, in terms of where things lie in the abdomen, Where we're kind of interested is this area up here. This is the right upper quadrant. So we kind of split it into the patient's right, left, and then upper and lower. And so basically, this is kind of all being the upper, basically, and this all being the lower. And as you can kind of probably imagine, all these things are not clear cut. Sometimes things show up in other places and things like that. Or, things like pyelo show up in different areas. Gastritis can show up in different areas, and you're right, the pain can radiate places. Absolutely. So good. So we're kind of focused in this area, kind of like here, really. The patient had pain in the right upper quadrant when we pressed in it, but we know the patient had pain in the epigastrium that radiated to the back. And so that's important to us. So things that we want to consider always are like an MI. We didn't talk a lot about that, a myocardial infarction or a heart attack. But other things you want to consider is like stuff going on with the stomach, gastritis or irritation of the lining of the stomach, peptic ulcer disease, ulcerations that can cause pain, and things going on with the liver and the gallbladder. So things like biliary colic, gallstones getting in the way, cholecystitis, inflammation of the gallbladder, and cholangitis, an infection that kind of originates from a stone getting stuck in the common bile duct, and then kind of an infection, therefore rising up the left and right hepatic ducts. Because as you kind of remember, the common bile duct goes like this. It separates into the left and the right hepatic ducts, and then kind of goes to the gallbladder. And so we know that if there's a stone kind of stuck here, all kinds of organisms can kind of then kind of travel up here and then infect this area, which is bad. And what we need to do is go in and take the stone out and relieve that obstruction. So we talked about a few things. Other things that we always want to consider is like appendicitis. It can kind of come in weird ways. I had my appendix out when I was in medical school, and it kind of did present very similarly, like in like mid-abdominal pain, not really like this classic like right lower quadrant abdominal pain. So you want to think about lots of different things. You guys talked about the kidneys quite a bit. You talked about a ruptured aortic aneurysm. Constipation weirdly can show up as a number of things. And then also, I kind of talked a little bit about like an ectopic pregnancy. If this was like a woman of childbearing age, getting a pregnancy test to make sure this isn't a tubal pregnancy, which is bad for is a bad thing to miss. Yeah, let's let gastroenterology do that. Agree, or the surgeons if it's a stone that you got to get out, we're definitely letting gastroenterology do that. If it's appendicitis, we'll call our friendly neighborhood surgeons. All right, so what do you guys want to do? You've decided that this is pancreatitis. What do we do for it? What do you guys think? You're onto something close. Consult gastroenterology, you could. This is something we see a lot in the hospital, and we treat often without gastroenterology, unless I'll tell you the times we do call them. Yeah, prescribe a medication to reduce inflammation. Yeah, should we look for the cause first? Yeah, totally. I love that. We always want to like look for the cause. I think you guys are all on to stuff. Treat dehydration. Samina, you nailed it. So there's three things often that we do and that are kind of the cornerstone of treatment of pancreatitis here. So what we would call this at my institution, we do these like little hashtags for our problems. So it would be like hashtag acute pancreatitis, hashtag leukocytosis is kind of what's going on with this person. So this is what we're calling our problem. It's acute pancreatitis. It's kind of happened recently. And then the other thing is this person has a leukocytosis. They have a high white blood cell count. And so this is kind of, what I want to show you. And I don't expect you guys to kind of, point out or be able to write this into your SOAP notes. But something I want to show you is like how we document these things, how I would document this in my note. And Chris kind of talked about like, should we look for the cause? I agree. What do we think is the cause? Going back to this person's history, going back to what we know about what's been going on. What do you guys think caused all this? Diet, fast food. Yeah. And eminently, that led probably to gallstones. Um, Good. So I think you guys are on to something, and that wasn't kind of a extraneous clue. You guys nailed it there. This person had, and what I'm communicating to people in my note is that I have thought about various things. So sometimes we put our differential diagnosis in here too. Like I considered, appendicitis, so the appendix isn't inflamed. I also considered a AAA rupture, but in the absence of hypotension, that's less likely. CT showed peripancreatic edema, which is characteristic of pancreatitis. Um, and then what I say is the etiology here is likely due to gallstones, given the right upper quadrant ultrasound that showed gallstones, sludge, pericholecystic fluid, which is that fluid around the gallbladder. And then though other consideration would be alcohol. But his pattern is not suggestive of alcoholic pancreatitis. The other thing that I kind of elicit in my note is that the amylase and lipase are greater than 3 times the upper limit of normal. That's what this ULN means. And imaging suggestive of acute pancreatitis. So I'm kind of telling them what my clues were that brought me to this. So what do we want to do? Samina mentioned that we want to treat dehydration. Yes, I agree. This person's probably not nauseous, vomiting, etc. So I want to do a few things. I want to treat their nausea. This ondansetron is the generic form of Zofran, which if you've ever heard of it, it's like a miracle drug. It helps with nausea. And then I want to give IV I know and IV hydration. So I want to give IV fluids. So this person probably might be admitted to the hospital if they can't keep things down. And then the other thing is pain control with oxycodone. And then in terms of oxycodone for pain, is it processed by the liver? Not so much so that, we're going to be concerned that it would interfere with anything at this point. And one of the mainstays of pancreatitis is pain control. So another thing that we could do is like IV pain meds too. So often we treat the pain kind of right up front. And we're not too concerned about, that eminently that would be an issue with the liver. The other thing that we often do is early feeding as tolerated. So, being able to then stimulate the pancreas kind of slowly and kind of often we start with like clear liquid and then later we kind of upgrade to do a diet as tolerated. And then the other thing that we kind of talked about here was we talked about this patient having cholecystitis and kind of getting to the root of what really happened here, which is contacting our surgeons to, take the gallbladder out after the pancreas has kind of had a little bit of time to cool down. Often that's done in an outpatient setting. And then I do put in my note here, my fake note, low threshold for repeat imaging. If we, have any concerns, basically, or if the patient's hemodynamically unstable, meaning they get hypotension and they're more tachycardic, because it can tell us or give us clues that something else is going on. Okay. Good. So let's keep moving here because I have a few more minutes to kind of get through a couple of things. So when we talk about pancreatitis, what causes pancreatitis? The 2 things I want you to remember when I say pancreatitis, you say alcohol or you say gallstones. Those are the two most common causes of pancreatitis, and by and large make up a lot of them. There's some weird ones like autoimmune things. Cystic fibrosis can cause it because you get issues with the lungs, you get issues with the pancreas. Congenital issues with the pancreas can cause it. If you have trauma, the thing that you see is like people like on your boards. The vignette is that like you're riding your bicycle or your motorcycle, and then like you get hit with blunt force trauma in your abdomen, which causes issues to your pancreas. And so that can cause your pancreas to be upset. And then here's our friends here, gallstones and ethanol. Other ones that you guys were spot on, but weren't necessarily the etiology here is hyperlipidemia. So high cholesterol can cause it. Yeah, lupus causes everything. That's true. I have a co-resident that calls lupus on everything. So yeah, it's true. When in doubt, just call lupus or like hemochromatosis, and you may be right or you won't be wrong, basically. So good. So here is how we diagnose pancreatitis. And basically you need three things, okay? So remember these three things. Number one is the typical abdominal pain. So that's epigastric pain that radiates to the back. It's almost always like that. Sometimes it's not, most of the time it is. Other things is amylase and lipase greater than 3 times the upper limit of normal. What is the upper limit of normal? Depends on your institution. Our guys was certainly greater than 3 times. They were in the thousands. And then characteristic imaging findings. What does that mean? It means diffuse, or diffuse meaning widespread, or focal meaning pinpoint enlargement of the parenchyma of the pancreas, meaning like the tissues, edema or inflammation of the pancreas. And then you can sometimes see fat stranding, which is like characteristic of inflammation as well. Other things that you may see is like necrosis or like dead tissue. You can sometimes see an abscess or like walled off collection of pus in the pancreas. You can see hemorrhage, you can see calcifications, and then you can see like fat necrosis as well. Can you get fluid in the retroperitoneal space? You usually see like edema and sometimes like fat stranding. And then with really bad ones, you can, and I'll show you a picture that's actually from a patient I took care of early this year that had really bad pancreatic pseudocyst, and you can see some fluid and edema there. Okay, let me clear this and let's keep going so I can get you guys out of here on time. So here's chronic pancreatitis. You might be like, okay, we know acute pancreatitis, but what does chronic pancreatitis mean? It means, chronic insults to the pancreas that causes chronic inflammation. And often what you see is calcifications. And you guys probably remember looking at an image before. So here's our right kidney, because we're looking from the feet up. Here's our left kidney. Here's our spinous process. Here's our liver. This cut, you can see the liver pretty well. Here's our aorta. And then here's our pancreas. Still not happy. And here's some calcifications which are showing up as white. And then you can kind of see the bowel here, and like admittedly this patient's like pretty constipated. There's lots of stool in the colon, but that's probably not the least of this guy's worries right now. And then the other things that you see is you kind of see these ribs coming into view in this cut as well. All right. And then there's an image or an arrow. We love when there's a good arrow. Okay, so one of the studies, and I know I'm a minute after time here. I'm almost finished here. One of the studies that I want to show you, because I love evidence-based medicine and I like when things kind of line up with evidence and it's not just things that we are doing in medicine, is something called the waterfall trial. That's what this is, and it's kind of named appropriately because it has to do with the way we get fluids in pancreatitis. And what this study did was a randomized control trial of fluids, and basically it delineated aggressive fluid resuscitation versus moderate resuscitation. Aggressive being a bolus of 20 milligrams per kilogram, followed by 3 milliliters per kilogram per hour. And if you're like, yeah, these numbers mean nothing to me, that's okay. If you want to like do math, our patient weighed 79 kilos. So you can see kind of what the differences are. And if we aggressively fluid resuscitated our guy versus moderately. And then the other one is 1.5 milliliters per kilogram per hour with a 10 milliliter per kg bolus, only in patients that were dehydrated or had hypovolemia or a low volume, or what we assume as their low effective blood volume. And what this showed is that, not surprisingly, but the way that we managed pancreatitis for so long was just, watering, the crap out of patients, giving them so much fluid to kind of help the pancreas. And what we found through this trial is that with aggressive fluid resuscitation, basically there was more complications, not surprisingly. So like volume overload was kind of an endpoint. So like pulmonary edema, etc. And we found that moderate resuscitation was better. And then in terms of the question in the chat, if we only aggressively treat if really hypotensive or sepsis, yeah, exactly. So if you think this person is needs more fluids, then sure. But if this is like your regular run-of-the-mill acute pancreatitis, then sure. And then finally, the other two things that are, what is sepsis? Sepsis is you need 2 out of the 4 SIRS criteria. So fever, tachycardia, elevated respiratory rate, or hypotension. You need 2 out of 4 of those. And then you have an elevated lactate. And so you can be septic without having bacteria in the blood. That's kind of a misconception. Bacteria in the blood is bacteremia. And basically, sepsis is like a severe infection. That's what we worry about. And everybody has kind of these sepsis guidelines in the hospital where you want to treat sepsis right away because it has a high mortality rate when you don't treat it quickly. Then finally, the other two aspects of treatment for pancreatitis would be pain control. We often use opioids. Some people are there's this sort of apprehension about using opioids, I think, in a lot of instances. But using it acutely for acute pain, I think, is effective and the cornerstone of pancreatitis. Then the other thing is nutrition. We like to do early refeeding, kind of wake the pancreas up, depending on their nausea, of course. We don't want to have them eat a bunch of Jello and crackers and pudding cups when they're really nauseous. We want to treat their nausea first. And you can avoid liver toxic drugs in this patient. I'm not concerned about acute liver injury in this person. Their liver enzymes looked okay from what we saw. And we didn't see signs of overt liver damage. So this person is okay. But like if somebody came in with cirrhosis, you would certainly want to be concerned about things kind of cleared by the liver. Okay. Finally, I'm 90% certain this is my last slide, and then you guys are free of me. Is things relating to the complications of pancreatitis. This is a scan in the upper right-hand corner from a patient that I actually cared for in the ICU. And you can see this big kind of, you guys are probably pros at looking at a CT at this point, this big kind of edematous pancreas. And you can kind of see these like, fluid collections gathering here, and this fluid collection here. And what we were concerned about is a pancreatic pseudocyst. And why is it a pseudocyst? So pseudo meaning false, is that it basically has a false lining. So it doesn't have, it's like a thin epithelial lining, as opposed to a like clearly walled off area. Excellent. That was it just Chris who can't see it, or can you all not see it? Uh-oh, Chris, what's going on? Okay, cool. You guys can see it. So you guys can probably see all the structures that I kind of talked about before. So here's liver, here's right kidney, here's left kidney, here's the spinous process, here's the pancreas. Again, still not happy. And then like dilated colon as well. And here's this kind of big fluid collection too that we're concerned about too. And you see these like air fluid levels, which is not good either. When you see kind of stuff settling out in the colon. All right, guys. I'm pretty sure it's the last slide. Yes, I didn't lie. That's all I have for you. Sorry for going over time. I probably talked too much there. But I'm happy to answer any questions that you all may have. I accidentally clicked on a slide here. But I'm happy to answer any questions that you guys have. Feel free to like unmute yourself. Feel free to also leave if this is past your bedtime or you've had enough of me. But I'm happy to answer any questions. I'll stick around for a few minutes afterwards and kind of address any questions. But otherwise, you guys are certainly free to go. Thank you so much for coming. I always enjoy my time teaching you guys. And hopefully we'll see you in a few weeks.
What was your major and everything before you started going to med school?
Yeah, excellent question. I majored in medical laboratory sciences, so I did a lot of stuff in the lab, and in a clinical lab, not a research lab. It's often a point of misconception. But I was like the person that you send all the labs to, and I did hematology and rapid response. So I did a lot of like differentials and I did like urine on the urinalysis bench, coagulation bench, and like did troponin work and stuff.
Nice. Nice. Where'd you go to school for
University
your...
of New Mexico.
Oh, that sounds like fun. Do you enjoy it?
I did, yeah. I'm from New Mexico, so it was nice to kind of be in an area that was familiar, and then I kind of ended up leaving.
Oh, that's nice. Awesome.
If anybody else has any questions, fire away. Feel free. I'm happy to answer anything. Where can you access the recording? I will let you guys know about that. I know previously it's posted to YouTube. Keep an eye out and circle back to us about it. We can kind of keep you in the loop. I'm not sure if they're posting it on the socials just yet, or where we'll kind of post it now. But I imagine it'll probably still be posted to YouTube, but I'm not entirely sure. So keep an eye out for that. Most challenging aspect of my school's med school curriculum. Um, Good question. I would say I really was like I had a hard time, I think personally, with um like anatomy at first and learning anatomy effectively. So it was kind of tough for me. And I went to an osteopathic medical school, which like a plug for them. I enjoyed my education. So I'm a DO, which at the end of the day kind of gets you to the same path. I really enjoyed learning osteopathic medicine. And thought it kind of added a lot to my education and my training now. I thought anatomy was tough, which is like kind of paradoxical for osteopath to say. Um, that and I think the other thing kind of shifting into a mindset where like this is what you're doing full time was kind of tough too. And then I know there was another one. Do you see multiple etiologies in the same patient? Yeah, all the time. Especially in internal medicine, we see, tons of things happening concurrently, and our problem lists get pretty long. In terms of internal medicine, for me, I knew that I liked a lot of things in medical school. Like I liked cardiology, I liked GI, I liked the respiratory block. I liked learning about everything and knowing a little bit about everything. Um, and then yeah, I don't think there's a QR code on here. Sorry. That's probably why you can't see it, Brenda. Sorry. Um, and I can give you guys the link here. Let me um, give you guys the link for this. I'll put it in the chat here. But yeah, I liked learning a little bit about everything, and that kind of drove me um, to, aha, there you go. There's the link to the quiz and stuff. But yeah, I liked learning a little bit about everything, and I thought that internal medicine kind of fit my personality most. And I wanted to, I didn't necessarily wanted to like do one thing. And I thought that internal medicine fit my personality and like the fact that I like to think and reason through problems and like take in information and be like a detective, if you will. I thought that was kind of aligned with my personality. And then I kind of developed a passion later on for addiction, and think that it's a field where you can do a lot of good for a lot of patients, and is one of the areas in medicine where you have treatments like Suboxone, methadone, et cetera, that are often or more efficacious than some of our other treatments in medicine. So that's kind of what was kind of appealing to me about addiction. Do you work med surge or do you just work in the ICU with more acuity? So as an internal medicine resident, we rotate through the wards. So admitted hospital patients, we have rotations in the ICU. And then I have my own clinic panel, and I'm currently in my clinic week right now. And so I see patients 3 half days a week in clinic, and I've seen them for the last 2 years now, and we'll see them into my third year. Um, and yeah, and then we rotate through kind of subspecialty like consult services and stuff too, but mainly like internal medicine specialties. What was the breakdown of grading assessments in med school? Yeah, good question. So in terms of my medical school, it was just exams, which can be like a change for a lot of people based on their undergraduate education. Um, Mine was primarily exams in each like organ system block. And so there was 2 exams in each block, and your grade was like made up of your exam scores essentially. Um, and then we had like clinical skills and stuff that was like made up of like participation and stuff like that. But that's definitely a change of pace. I think for a lot of people is just having exams, which is like a little bit tougher. Um, and then in terms of like how things are graded, I think a lot of schools are going to like a pass fail curriculum, which my school transitioned to about halfway, like amidst like COVID. And so I think a lot of people are doing that since boards went pass fail as well. But I hope that answered your question. Um, you're doing a bachelor's in respiratory therapy and plan to on going for MD or PA. Any tips before taking the MCAT? Yeah. In terms of taking the MCAT, I would say do my big hot take is like do several practice exams before taking um the actual MCAT. I think a lot of people are like, oh yeah, I took the courses, this would be cool. Including I the first time I took the MCAT, which is not right. And so I think it's helpful, in the same way that you wouldn't train for a marathon and just go out and run it. That would be bad news bears. That you would like do practice beforehand and you do long runs and sprints and things like that. In the same way, you would want to do, questions, you'd want to do full length tests and stuff and kind of prepare yourself. Because a lot of it is knowledge, but a lot of it's like having the stamina to take this immensely challenging test. So I would recommend doing that and kind of having the grit to get through that kind of 8-hour test. Um, you might not be able to. Yeah, certainly. So, accommodations I think happen a lot depending on who you are and like what your accommodation is. And so I would say, and I'm happy to like answer your question a little more specifically. If you do work through Motivate MD and like help advise you too, depending on your circumstances. But yeah, a lot of people have accommodations for a number of different things, and end up doing well, and being accommodated for their for what they need to, whether that's chronic illness or what have you. So I think it depends on what is going on or what it is, and depends on the program likely too. But I know like my program does.
Can you actually tell me your day in the life of what you're doing? Like, tell me a bit more about your day in the life.
Totally. So today, for instance, was kind of no, it was kind of an atypical day, but I'm in clinic this week, so like maybe I'll start with like yesterday, because it's more typical. And um, so basically, our schedule in residency in my program is like a 3+1 schedule or an X plus Y, meaning you have 3 weeks where you're on a rotation, and then your Y week or your +1 week is your clinic week. So I'm in that like Y or that +1 week where I'm in my clinic. So like we have different subspecialty clinics that we go to regularly. One of my clinics tomorrow morning would be an addiction like detox center. So I go there in the morning and admit patients to detox from various substances. Um, but like 3 days a week during my clinic week, I go to I do other subspecialty clinics, but 3 half days a week I do my own clinic. So yesterday afternoon I had my own clinic schedule and half day where I saw 4 patients of my own, and kind of go and see patients. I make the assessment and plan for them, and then like staff with your attending and kind of run it by them and say like, here's what I saw, what I did, and here's what I want to do. And like sometimes I'll give you feedback and say like, oh, you want to think about this, or I have nothing else to add, or whatever. And so like that's kind of that. But preceding this, I was on wards, hospital wards. And so as a senior resident, I had 2 other interns working with me, interns of first year resident. And we would admit patients to the hospital from the emergency department, and then round also on our patients that were already on our list. So you're doing everything from, managing all the problems that they came into the hospital for, and then you have different call days where you admit patients from the emergency department, whether that's like early in the day or late after you round. But that's kind of what I was on before. And then yeah, now I'm in my clinic, which is like a primary care clinic, like probably most that you guys may be familiar with when you think of like primary care.
Nice. Is it tiring for you?
Oh yeah, it's exhausting. I'm not gonna lie. I didn't get tired. I didn't get tired until I got to residency, really. I had a lot of energy when I was in medical school. I felt like I compensated pretty well. And then I think I got old, and we work a lot as residents, and it's certainly high stress, but I think the experiences that you have with like your co-residents and stuff kind of make up for it. And you have this like unparalleled opportunity to learn so much stuff.
That's nice. Any advice you would recommend to a pre-med student who's interested in working in this type of field? Because I'm a pre-student myself, and I might be interested in working in this field. And some other friends that I know really want to work in this type of field, but they are extremely
Yeah.
like they were telling me, where can I start? How do I do this? Like, any advice you want to share?
Yeah, good question. One piece of advice I often give when I work with people on Motivate MD's platform is, um, don't don't feel adverse or discouraged to taking like gap years. I had two gap years from when I graduated from college and when I started medical school. And like, I'm so grateful for that time because I didn't spend, all this time, in an arduous, curriculum. And I had time to like live my life and work and do stuff. And I think that that's really important to like building who you are. And I think a lot of people like feel this like rush and this urge to like get into medical school like imminently. And I think it's okay to take that time and like to live your life and like grow and be um whatever you want or do whatever you want in that time. That's one thing. And then I would say the other thing would be just to like follow and do your passions. Even as a pre-med, get involved in the volunteer stuff that you're passionate about or that you have an interest in. It'll make it a lot easier when you have to like do that stuff. Shadow the physicians and stuff that like make it feel less like a checkbox that you have to do to get into medical school and more stuff that you really enjoy doing. And then same thing goes with like all the research stuff too. Do the stuff that you enjoy and then the time will go by a little bit faster too.